So I'm going to be giving a talk. The topic I was given was indications for herniated nucleus pulposus. Pretty broad, and I have 20 minutes. And so I thought about this from the standpoint of some of the patient interactions I've had at this point and some of the questions I've had, and tried to come up with kind of some of the common issues or questions that I've seen to this point in an attempt to kind of narrow it down. And so these are some of the things we're going to be talking about. And we're going to use a fake patient to guide us along through this. And this is Mr. Jones. Mr. Jones is generally healthy, no significant past medical history, drives a box truck. And before 2 weeks ago, had no real complaints about any back, neck, or upper or lower extremities. And 2 weeks ago, he was doing a delivery where he felt a pop in his back. And he's now been complaining of intermittent pain radiating down the posterolateral thigh, as well as, so that he took the next day off, and while he was sleeping on the couch, he fell off and hit his head, and then he's been having numbness into his radial 2 digits. And maybe the most important detail is that he's married to your surgical scheduler, so he's in your clinic with no primary care, no treatment, no imaging or nothing, but he's still here. And the first question he's asking is, Doc, what's wrong with me? And based on his history and his complaints, the strong suspicion that there's some component of a herniated nucleus pulposus. And so getting into the cervical side of that, cervical herniated nucleus pulposus has a multitude of different clinical pictures. And this was addressed in this paper here on the right. It was actually out of a radiology journal, out of a, done by a couple of radiologists looking at the different pictures depending upon where the disc herniation occurs and how it manifests. So they kind of broke it down into median, paramedian, and lateral. And so because of the fact that you can have so many different, if you look at what those clinical pictures are, each of them would be could be an hour or 2 hour talk in and of itself. And so I'm going to try to just focus on what Mr. Jones has going on, which is a lateral or radiculopathy picture. And then looking at it, because of that varied clinical picture, getting epidemiologic data for cervical herniation or disc herniation is rather difficult. But this study that's out of Mayo seems to be frequently quoted within the literature that looked at a population study for about 14 years. And they estimated that the incidence is about 89 cases per 100,000 patients. And then when they looked at those patients with cervical radiculopathy, 22% of them were a result of a cervical disc herniation. Lumbar has been studied a little bit more frequently and more thoroughly, and they estimate, depending on where you're looking, somewhere between 1 to 3% of the adult population per year is affected by a symptomatic lumbar disc herniation, which, if you do the math, it equals about 3 million disc herniations per year. And it also is worth emphasizing, this is a part of the assumptions from a McCullough paper that we'll be looking at later, but a significant portion of these disc herniations, in addition to these ones that I'm referencing as being symptomatic, 20% of people less than 60 years will have asymptomatic disc herniations as well. And so as we're talking to Mr. Jones, pick up my model and start describing the anatomy of what I think is going on. And we get into the fact that within the intervertebral disc unit, there's 3 components to it: the end plate, the annulus, which is primarily type 1 collagen and has tensile properties to kind of contain the nucleus, whereas the nucleus, which is type 2 collagen, is a shock absorber with high water content. Its design is to transfer forces to the adjacent components, namely the annulus and the vertebrae. And so the pathoanatomy, or what we think is going on with Mr. Jones and why he's having these complaints, is you have a disruption of the annulus with a loss of resistance to poop stress, and the annulus fails to do its job, which is to contain the nucleus, and the result is a herniation beyond the usual location. And the implication of significance of this is you need to be fairly young, and that you need to have soft, pliable nuclei or discs in order to herniate. And therefore, older patients where the desiccation process has begun, they're less prone to developing this disease process, at least acutely. So this is just, again, I'm trying to talk to, looking at this patient in particular. I thought this was an interesting study looking at the biomechanics of, at least in regards to his lumbar complaints. This was a study looking at how does the lumbar disc herniation, the pathophysiology of it, and they looked at a variety of different exposures using this apparatus you can see over on the left. And their conclusions were that the combination of a lateral bend, flexion, and axial rotation within 15 minutes of vibratory exposure may put you at risk for an annular tear and subsequent herniation of the nucleus pulposus in vivo. So I personally think this is pretty interesting, and especially in the setting of Mr. Jones being a truck driver, and I start telling him this, and I look over and I realize he's asleep. And he's asleep rather, and he's wondering, but why does my leg and arm hurt so much? And so I go and I pick up my flyer for disc herniation, and I start showing, I say, look, the nerve is compressed. But it turns out that as I was doing research for this, that was what I would have assumed, but that may not necessarily be the case. And one of the reasons, or piece of evidence that kind of goes against that, is this really interesting series. It was out of Australia. It was published in the 90s, where they looked at 193 consecutive patients of patients undergoing lumbar surgery under local anesthesia. And they stimulated different tissues and asked the patients while they were in this kind of, while they were under local, as to what sensations they were having. And their conclusions were that the normal nerve root was completely insensitive to pain. So maybe it's not just pressure. And then I flip the page and go, look at this one's so red. Maybe it's because the nerve is inflamed. And this seems to be more of what's going on in terms of why symptomatic herniated nucleus pulposus happens. This is an animal study looking at rats, where they looked at they kind of created three different scenarios. One group had an iatrogenic disc herniation. One group, they injected herniated nucleus pulposus tissue or disc material onto the nerve. And then the third one was adipose tissue. And then they looked at the animal responses to painful stimuli afterwards. And their results showed that it wasn't just the mechanical stimulation of the nerves was not sufficient on its own, but instead there needed to be some sort of inflammation or response from disc herniation or the injected herniated disc material. Getting further on the idea of inflammation being at the root of this, this was another animal study looking at dogs in terms of lumbar nerve roots, where they clamped a nerve root for 3 weeks. And mechanical compression of the nerve root led to increased inflammatory markers, including T cells, as well as inflammatory cytokines. So again, more evidence that maybe it's not just the mechanical compression, but there's also an inflammatory component of this as well. So maybe it's both the compression as well as the inflammatory process that's contributing to this. And this seems to have a little bit more data. So this is another animal study looking at rats this time, where 4 different groups, an iatrogenic disc herniation, one where they simply displaced the nerve root without any other further insult, and then a combined mechanical displacement as well as exposure to herniated disc material. And again, looking at the animal's response to noxious stimuli. And what they found was that mechanical displacement, i.e. pressure, or exposure to the nucleus content did not lead to any behavioral changes, but rather it was the combination of these two. And getting back to this local anesthetic study, maybe looking this time at human patients, their subsequent, in addition to showing that the normal nerve root was insensitive to pain, they also noted that sciatica could only be produced by stimulation of the swollen, stretched, or compressed nerve root. And this was another study kind of showing this as well. This is a JBJS article from way back in 1958. And the objective of the study was to look at whether a disc pressuring or to prove that disc pressure on a lower lumbar nerve root causes sciatica. And this showed one of their series had 8 patients with a intraoperatively confirmed unequivocal disc herniation pressing on either L5 or S1. And what they ended up doing, I don't know if this picture is projecting on your screen, but they actually ended up putting a nylon suture around the disc, around the nerve root rather, after the disc material had been removed. And then post-operatively, somewhere day 1 to day 7, stimulated it by just gently pulling on these nylon sutures and asked the patients to describe the sensation that they were having. What they ended up describing was a sciatica-like sensation similar to their preoperative status. And then the conclusion was that mechanical stimulation of a recently compressed nerve creates sciatica-like pain. So I get done telling him all this, and he's like, well, aren't you going to do an exam? I said, yeah, sure, that's fine. But these are some evidence-based clinical guidelines for treatment of both lumbar disc herniation as well as cervical radiculopathy. And interestingly, I thought, in spite of the fact that certainly be examining a patient regardless of the NAS opinion is that they may be considered in evaluating patients, at least a special provocative test, namely shoulder abduction and Sperling test. Whereas for lumbar disc herniation, the physical exam are recommended for diagnosis purposes of radiculopathy with a strong rate. But looking deeper into why that is, this is a study looking at patients with lumbar disc herniation on myelography that was subsequently confirmed at the time of surgery, and then they went back and looked at what their patients' physical exam findings were, including sensory disturbances as well as strength findings. And they found that there was a fairly strong positive predictive value both for ankle dorsiflexion loss as well as sensory abnormalities in the L5 and S1 distribution that could somehow that would be effective at localizing the level of the disc herniation. And this is another study that looked at the value of different tests in addition to those sensory and strength evaluations referenced on the previous slide. And this just demonstrated that while all of these hyperextension bell tests, as well as straight leg and contralateral straight leg, while they were all somewhat useful, the best sensitivity for the diagnosis was a straight leg raise, and contralateral was the most specific. And then getting further into the question of what other physical exams should we be doing for this patient, sensitivity of the supine versus the seated straight leg raise is an article that was published in 2007 comparing these two, and the supine straight leg raise was found to have a higher sensitivity, and that leads to this NAS recommendation on the right that the supine straight leg raise should be is suggested for use in the diagnosis of a lumbar disc herniation. Mr. Jones looking to get going. It says, don't I need an MRI? And because I'm an orthopod, I said, well, we should probably get an X-ray because you're in my clinic, and let's get some X-rays. But as I looked into this a little bit more, the utility of X-rays in terms of indications for surgery, or at least diagnosis, may be a little bit premature. This is from the American College of Radiology, looking at the utility or their recommended imaging for a patient where you have a suspicion of cervical radiculopathy. And you can see down at the bottom, they're usually appropriate as an MR, and radiography may or may not be appropriate. And this is another study that basically concludes, that you can see the conclusion on the right there, saying that non-acute care, no structural disease, does not seem to be good evidence supporting the utility of plain radiographs. That being said, going back, this is, I want to clarify, at the time of diagnosis, but after 6 weeks, it seems to be consistent that at least static X-rays for cervical disc herniation or suspected cervical disc herniation are appropriate and indicated. This study is looking at whether or not we needed to add on flexion extension. This is a study out of Spine from 2007 that these were atraumatic patients complaining of either axial neck, radicular, or myelopathic symptoms. and they looked at the whether or not the addition of flexion extension films had any impact on the management of these patients. And essentially their conclusions were that there's no change in management for any patient in spite of the fact that 1% had a slip and not seen on static x-rays, and there were 3% seen with dynamic x-rays. And so their conclusion was that they essentially did away or felt that the use of flexion extension films may or may not be beneficial in terms of changing management for the patient. Lumbar back, in regards to his low back complaints, 6 weeks again is a number that shows up, and this again shows that the utility of x-rays when you're getting to the point not of diagnosis per se, but of considering surgical management is crucial for identifying and making sure that you're identifying any transitional anatomy or abnormalities which could lead to a wrong level surgery. And the patient comes back and says, aren't MRIs better than x-rays? And the NAS guidelines would suggest they are. And this is just showing here kind of, not really anything earth-shattering here, but this is just saying further MRI, CT myelo for cervical. And this is also a consensus statement looking at additional confirmatory tests. And they're just saying that MRI is recommended as the appropriate non-invasive test to confirm the presence of a herniated disc in lumbar patient, a patient with concern for lumbar disc herniation. As a side note, they actually did not address the question of radiographs in their guidelines. So here are some imaging takeaways. Just in the interest of time, keep moving along. So Mr. Jones leaves, and then x-rays come back, mild degenerative change, nothing new. He calls you back in a couple of weeks and says symptoms are not improving. So you order an MRI, which comes back and you more or less confirms what you were suspecting, and that there's disc herniations in the lumbar and cervical spine, which kind of correlate with the symptoms. So you bring them back to your office and question of, do I need surgery? Now we're getting into the indications part here, and the absolute surgical indications, what I could see was a progressive neurologic deficit or lumbar in the lumbar spine, cauda equina syndrome type picture. Mr. Jones doesn't have any of those, but it gets a little bit more complicated. And so this is a systematic review that was published relatively recently, looking at the prognosis of cervical disc herniation with radiculopathy. And their conclusions were that substantial improvements tend to occur within 4 to 6 months of onset. And time to complete recovery was 2 to 3 years, and it happened in approximately 83% of patients. And similar for the natural history of lumbar disc herniation, this is kind of a landmark paper, Dr. Weber's paper from looking at 126 patients in a cohort that was randomized and comparing their outcome between surgical and non-surgical intervention. And while that conclusions in terms of the natural history, he commented on the fact that natural course of the radiculopathies are more encouraging than expected. And finally, that at 4 years and beyond, there was no difference between whether or not between the surgical and the non-surgical group. Another big paper here looking at this, the natural history of things, Dr. McCullough's paper, which I had up previously, and this was more of a literature review that he had done. And so his conclusions were that over time, with or without surgery, after 5 years, surgical outcomes are essentially the same. And I thought this line was interesting, in that in the end, the decision to operate with a lumbar disc herniation rather depends on patient preference rather than necessity. And you can see over here some of these assumptions that were listed in the paper. Surgical intervention will improve the short-term outcomes, but long-term studies show little difference between the group of patients treated surgically and non-surgically. So again, takeaways here from the natural history in terms of the patient's question of whether or not he needs surgery. You can counsel him that cervical herniated nucleus pulposus, get a good outcome, symptomatic resolution, typically within 4 to 6 months. I know that systematic review had said 2 to 3 years, but from other places seen 4 to 6 months. And lumbar patients similarly have a good outcome, and greater than 90% of them do quite well within 3 months. And surgery may shorten the duration of symptoms, but they come with the risks of surgery. And the NAS recommendations similarly reflect this, in that saying that majority of patients will improve independent of treatment. And for the work group consensus for cervical spine, symptoms will be self-limited and resolve spontaneously without specific treatment. So the patient comes back to you, and it's been 6 weeks, and he says, I can't take it anymore, I want surgery. When should we do it? So in terms of indications and the timing of surgical indications, this was a study looking at 270 patients with cervical or lumbar radiculopathy or herniation complaints. And 169 patients underwent surgery for cervical disc herniation. And of those, 52% underwent surgery within 60 days. And when compared to the patients who underwent surgery greater than 60 days, this cohort showed a greater improvement in their health-related quality of life, and also gained higher quality adjusted life years. And their conclusion was that there's potentially a better functional outcome for patients who undergo surgery within 2 months of symptom onset for cervical radiculopathy in the setting of herniated nucleus pulposus. And then this is a meta-analysis looking at for the question of timing for lumbar surgery. You can see the different time frames here: 60 days, less than 60 days, less than 3 months, but all these showed better outcomes or health-related quality of life at those time points compared to waiting longer. Now, the NAS guideline for lumbar, there's none given for cervical, but for lumbar prior to 6 months. And they also concluded that earlier surgery, 6 months to 1 year, is associated with faster recovery and improved long-term outcomes. Just as a side note for me, in terms of looking at this, the idea of weakness being found on exam, maybe pushing me one way or the other towards considering surgery. I thought this study looking at 56 patients with ankle dorsiflexion weakness and a confirmed diagnosis of lumbar disc herniation was interesting. They measured their ankle dorsiflexion strength preoperatively, as well as at 6 weeks and 1 year. And you can see down here that the duration of preoperative ankle dorsiflexion weakness did not correlate with the recovery. And so just in terms, something to keep in mind in terms of the whether or not the presence of weakness is impacting decision-making regarding timing, not whether or not to go, but whether there's an urgency to it. I thought that was an interesting paper. And then Mr. Jones says, what if I don't want to do surgery? And so I think part of this, at least with regards to cervical radiculopathy, this study suggests that non-surgical treatment, while it's appropriate, it may lead to slight worsening in certain outcomes, specifically the ability to perform activities of daily living. This is a study looking at 503 patients. Of those, 246 had radiculopathy, and 155 of those 246 had follow-up data for that diagnosis. And looking at the group with follow-up data, 1/3 of them ended up undergoing surgical treatment. And when they compared the surgical treated to the non-surgical treated for radiculopathy in the setting of a cervical disc herniation, not only did they have they showed an ability to perform activities of daily living compared to their preoperative status, but they also had a higher satisfaction, better neurologic outcomes, and better improvement pre versus post-op pain compared to those patients that were treated non-surgically. Now, that being said, there are a lot of common non-operative treatment considered for cervical herniated nucleus pulposus, both cervical and lumbar herniation, disc herniations. We're going to look at some of those briefly. I thought, in terms of the benefits of NSAIDs, corticosteroids, antidepressants, you can see all of them looked at. This was a meta-analysis looking at specifically at lumbar disc herniation. And their conclusion, you can see there, did not favor active treatment over placebo. And the efficacy and tolerability of these pharmacologic interventions for these diagnoses is unclear. So not exactly a strong supporting statement for the use of pharmacologics, and NAS kind of follows down on this as well. With regards to the question of pharmacologic treatment for cervical herniated nucleus pulposus or cervical radiculopathy resulting from disc herniation, no study showing pharmacologic treatment has any benefit. And then looking at lumbar, the only thing that really came out that was definitive was that the use of TNF inhibitors, they recommended against it, but otherwise insufficient evidence. And with regards to anti-inflammatories, which seem to be pretty common in terms of treatments for this, they kind of raised the point that this could be a future direction for research, but inconclusive data at this point. Similar, another commonly prescribed treatment for the diagnosis of disc herniation, physical therapy, and NAS also concluding insufficient evidence for both cervical and lumbar herniated nucleus pulposus. And this was just an interesting study, I thought, that kind of argued against it, where this 44 patients who were already scheduled to undergo a selective nerve root block, half of them were randomized to undergo a course of physical therapy 4 weeks after the intervention, and looking at their low back pain disability questionnaire as well as their numeric pain rating, and no difference at any time point, with the conclusion that physical therapy does not seem to have a significant impact on the outcome of patients with lumbar disc herniation resulting radiculopathy. But again, to clarify, the NAS guidelines do not say definitively one way or the other. How about for cervical? This was a recent study out of Spine that was looking at epidural steroid injections, and their endpoint was, or their primary endpoint was, whether or not these patients, from looking at a large administrative claims database, almost 192,000 within 8 years, whether they underwent subsequent surgery. And this was for all diagnoses, not just cervical disc herniation or cervical radiculopathy. As I was saying at the beginning of this, there's a lot of overlap in terms of different diagnoses resulting from associated with cervical herniated nucleus pulposus. But their conclusions I thought were interesting in that at 6 months, 11%, and up to 5 years, that jumps up to 22% of patients in this group ended up undergoing surgery. And patients that were undergoing surgery, male gender and age 35 to 54 were more likely, and patients that underwent multiple injections were less likely to undergo subsequent surgery. Epidural steroids for lumbar, looking at, this was a prospective double-blinded randomized controlled trial. You can see there's 5 different groups here, with one of which being a transforaminal epidural steroid injection for patients with MRI confirmed lumbar disc herniation symptomatic. And the primary outcome they looked at was at least 50% relief at 1 month post-injection. And then secondarily, they also looked at patient function and disability as well as the duration. And they found that, that this is in fact compared to placebo, as well as compared to a local anesthetic in isolation, that there is some utility or benefit of undergoing transforaminal epidural steroid injection, at least with the primary outpoint or endpoint of pain relief at 1 month. But no matter what treatment these groups had, over time, all of their relief is diminished. And it kind of a follow-on to the previous study I just showed about cervical injection for disc herniation or radiculopathy. 36% of patients who underwent the transforaminal injection in this group had undergone surgery within 12 months of injection. So just get back to the NAS guidelines. They have a grade A recommendation, strong recommendation that they can provide 2 to 4 weeks of pain relief, which seems to be consistent with what we saw in that randomized controlled study. But at 12 months, it's insufficient evidence. And then cervical, a little bit less conclusive and may be considered with C recommendation. So treatments in terms of non-surgical options, many of the commonly used pharmacologic treatments do not have strong evidence, nor does physical therapy. There is some evidence suggesting that epidural steroid injections are effective at providing short-term pain relief for the diagnosis of disc herniation, but a significant percentage, whether you're talking about cervical or lumbar, end up undergoing surgery. And there's no definitive evidence that any of these treatments alter the natural course of disease or treatment. So as part of the indications discussion, Mr. Jones is trying to figure out where he's going to end up. He wants to know what he's going to be able to do in light of his complaints. So looking at cervical radiculopathy, this is a prospective randomized group study where they grouped patients into 3 different groups. One underwent a surgery, one underwent collar alone, and one underwent physical therapy. And so they looked at VAS, muscle strength, and sensory loss at pre-treatment, 4 months and 1 year. And their results showed that at 4 months, the surgery group seemed to be doing better than non-operative in regards to those outcomes. But at 1 year, all outcomes were similar. And so these conclusions you can see down at the end, slow improvement with conservative treatments, as well as recurrent symptoms in the surgery group make the 1 year results about equal. So I took this to mean no matter what you do, things are likely going to get better. But with regards to cervical herniated nucleus pulposus, the benefits seem to be with regards to rapid relief. You can see it there on the left in terms of the NASC guidelines, rapid release of symptoms when compared to the medical conservative treatment. And so both paths lead to a final destination. What does that destination actually look like? And we come back to this group. It was, again, 500 patients. And they looked at about 155 of them with cervical radiculopathy in the setting of a disc herniation. And it seems, based on their studies, that a significant number of patients from this group still had persistent symptoms out to 2 years. 80% of surgical patients were satisfied or very satisfied. That means 20% were not. And similar non-surgical patients, only 60% satisfied or very satisfied. And again, they reference important to point out in terms of where the patients are going to land. Surgical patients had a significant improvement in their ability to perform their activities of daily living, whereas non-surgical actually had a slight worsening in their ADL functionality. And in regards to lumbar, this is a sport study looking at lumbar disc herniation. Outcomes SF36, physical function, ODI, with time points 6 weeks, 3 months, 1 year, and 2 year. Kind of concluded that surgery group was doing better at all time points, but the difference between the two was narrowing at 2 years. And their conclusions of their study show that persistent sciatica improved in both surgical and non-surgical groups. To me, again, says no matter what you do, things are likely going to get better. But this is the main study group in terms of what does the final end state look like. And this is a 10-year follow-up that was obtained through male questionnaires sent out at regular intervals. Of their 507 initial patients, 400 of them responded back with outcomes at 10 years. The patient reported complaints of leg and back pain, as well as functional status and their satisfaction with the intervention. And you can see that they did have good outcomes in that 69% of patients versus 61%, no significant difference, reported symptoms in their predominant complaint at the time of surgery. And 71% versus 56% was satisfied with their current status. But conclusions can be reached from this in terms of counseling the patient where he's going to land. Patients have a significant portion of these patients have a disability at 10-year time point, regardless of whether or not they undergo surgery or not. And this is again reflected in the NASC recommendations. Surgical decompression, they're a little bit stronger than what you see with the cervical recommendations, provide better medium symptom relief compared to medical outcomes. But you should also see down there at the bottom, a substantial portion of patients who undergo surgical decompression will have chronic leg or back pain. So to wrap it up, for the indications for this diagnosis, for acute cases, at least when you're seeing these patients initially, the herniation is typically self-resolving and surgery is not necessarily indicated, and the list of absolute surgical indications is rather limited. Relative indications means that patient preferences play a significant role in determining whether or not surgery is going to be undertaken. 6 weeks seems to be the magic number, and both for cervical as well as lumbar, surgery can offer comparable long-term outcomes to non-surgical treatment. Data seems to suggest that the short-term disability may be minimized with surgery compared to non-surgical treatment, but that comes with the risks of surgery, both for cervical and lumbar disc herniations. If you're considering surgery, some data suggested better outcomes with earlier surgery, somewhere between the 2 to 6 month window, if you're kind of taking all this data together and putting it into kind of a takeaway, 2 to 6 months after onset of symptoms. I think this is probably a very important, one of the more important points I took away from doing the research is no matter what you choose, you need to set expectations that there's a good chance that there's going to be persistent pain or disability and subsequent patient dissatisfaction. So while we get hung up on comparing the outcomes and the indications and whether or not surgery is better to non-surgery, when you look at those kind of the final slides that I just showed there, whether you're talking about cervical or lumbar disc herniation, regardless of whether the patient's undergoing surgery or not undergoing surgery or being indicated, there's a significant portion of those patient groups that seem to have persistent pain at out to 10 years, at least in that main study. And that's all I got.
Very nicely done.
Yeah, that was really nice, Micah. Yeah, a lot of
topic.
Yeah, really nicely covered.
It seems like a small thing that we do, but there's a lot of gray on how you manage it. A lot of gray, diagnostically, therapeutically, and frankly, I think, to be honest, it takes a great deal of experience to know how to handle them. And my sense is our literature, our evidence is a little bit insufficient relative to clinical experience in knowing how to handle these. We try to parse it out. The sport trial is great, but because of all the crossover effect, even in that trial, you tend to have to come at it with a great deal of just clinical experience. So, leaning on people like Bruff, who have vast decades of experience managing these is really important.
What you talking about, Willis? Vast decades? Shit.
Yes.
I feel like the gal in the Doctor Strange movie now, the bald woman. Holy smokes.
and equally importantly, having colleagues, albeit anecdotal, who have experienced the issue themselves personally,
right,
is also really helpful. And it's not, it makes it personal to a degree, and I think you get feedback from that kind of interaction that is really, really helpful.
This is one of those things, Bob. I think it's the art of what we do, because the studies, and as Micah very eloquently pointed out, given the literature review that he did, we don't have hard evidence. A lot of these would get better, but the period of time of suffering and the disability that comes along with that is just not tolerable in most societies. You just cannot function with the kind of discomfort and symptoms people get from these conditions, and that's why we operate on them. Because the natural history is, if you put somebody in a box for 2 years, they're probably going to end up being kind of okay, but 2 years of their lives are gone. I don't know what the duration would be for some of these folks. If you just leave them be.
Right. Agreed. To some degree, I think of disc herniations in the literature we have a little bit like kyphoplasty, where you have some literature that questions surgery and its merits, but you sort of inherently know there's benefit to be had in a group of patients. So you can get people that argue, well, you don't really need to have surgery. just for pain. I don't think there's much argument for progressive neurologic deficit, but on the pain side, you can make a reasonable argument on either side for both of those issues. Yet we just sort of inherently know there's a group of people that probably benefit to a reasonable degree.
Yeah, it seems like the analogy that you said, remember from residency, people using is like the area under the curve, where the two curves may end up meeting at a similar place, but maybe with surgery, as long as you're willing to accept the risk that goes along with it, that you can decrease the area under the curve, which is you kind of alluding to, like makes it more appealing for people if it's really that significant amount of disability. So.
Right. Anyway, great job.
Thank you.
Any other comments? All right. I see Dr. Gazarian on the line. Good to have you on, bud. You seeing some of these? Yeah. Are you seeing some of these?
I am, and actually, it's as a new surgeon, it's really a learning process. So I had a lot of patients initially who came to me and they were miserable, but they didn't quite meet the indications for surgery. And I told them exactly the way it was. A lot of them went to another surgeon and had surgery. So, it's a
tough thing to see, but
yeah,
you got to hold the line and do the right thing. I'm
exactly.
sure you'll see lots of people who have that stuff, and other guys or gals will tell them they're going to be paralyzed, with a cervical disc herniation or myelopathy, and that's just where you got to stay principled.
Yeah, stay principled. My God, I hate when people say that. Oh my God, it drives me crazy.
So I started drawing like a little diagram for them on the back of, let's say, a piece of paper. And I said, we're going to start with this. If this doesn't work, we move to this and then this, so that when they leave, because sometimes they forget like what I tell them, but they can refer back to this paper and see that I gave them options. I didn't just leave them to be in pain. And so if the pain persists, we go down to the next thing.
Mm-hmm. Well, good.
So I never I forget one of my 3 legal lawsuits that I had was a law student that came to me, and I didn't do surgery for the disc, but because it was not indicated, she went to someone else and then sued me for not doing surgery because somebody else did it. Never went anywhere, but she went and she became very miserable and came back. But so they can stick to your guns
On either side.
Yeah.